Chapter 2 What is Psychopathology and Controversies in Classifying Psychiatric Disorders. Carl Jaspers is considered the father of psychopathology. His work, General Psychopathology, has become a classic in psychiatric literature. His major contribution has been to delineate the diagnostic features of mental illness. He believed that mental illness, in particular psychosis, should be evaluated with regard to the abnormal phenomena that accompany, for example, hallucinations, delusions, and thought disorders, rather than the content, which is the focus of psychoanalytic school. Thus, he distinguished between form, which can be primary or secondary, systematized or non-systematized, etc., and content, which might be persecutory, nihilistic, etc. He did not subscribe to the notion of understandability and described primary and secondary delusions, autochthonous or primary delusions as arising from abnormal biological processes, and secondary delusions from underlying abnormal phenomena such as hallucinations. For example, a voice telling a person that he is being watched, leading to beliefs that there is a camera spying on him. There are two broad approaches to psychopathology. The first is philosophical in nature and asks questions such as whether mental illnesses truly exist, how best to conceptualize it, and whether the syndromes we recognize as disorders are discrete entities naturally occurring in nature or social constructs that change over time in different cultures and different eras as society tried to make sense of the human behavior. The second approach is clinical. It deals with issues such as etiology, symptoms, course, etc., and attempts to demarcate the distinction between symptoms of disorder and psychological phenomena found in general population. It was adopted with particular enthusiasm by DSM and later ICD, but with less emphasis on rigid diagnostic criteria and more on clinical judgment. Philosophical approaches to defining psychiatric disorder. Kendler discusses three approaches of understanding the underlying nature of psychiatric disorders. These are realism, constructivism, and pragmatism. Realism is the perspective of biological psychiatry and is taken by most of the psychiatrists, and asserts that mental illnesses are real in the same way as a broken bone or cancerous tumor, and claims that most mental illnesses will eventually be identified by their genes, the cerebral pathways, or markers. Counter-argument to realism is the failure of identifying pathophysiological underpinnings of most of psychiatric disorders. Constructivism is the view of the anti-psychiatric school and claims that psychiatric disorders have no biological reality and are constructed by humans in the same way as fashion or music genres. That is, they are products of social convention and human activity and not innate in nature. Many syndromes as recognized psychiatric disorders are in response to social and political climate of the time. For this, DSM has been subject to much more criticism than ICD because of the rigidity with which the criteria has been applied in clinical practice. Pragmatism, sometimes also referred as utility, it is a middle ground between the realist and the constructionist perspectives, and states that psychiatric classification and the conditions named there are based on what works and is useful rather than what is real. Jablonski contends that there are transdiagnostic commonalities which makes validity of specific disorders as discrete entities futile, and argues for comparative validity, that is, criteria based on current scientific knowledge representing improvements on previous models. Let's discuss some counter-arguments to pragmatism. According to Wakefield, it detracts from the scientific basis of psychiatric diagnosis. And Kendler says the failure to fully understand the underlying conditions and the suffering it causes is disrespectful to the patient and their families, and they may even be labeled as not really sick. This also undermines the profession, as the general public might see this as not doing anything real and as not belonging to a legitimate biomedical discipline. Cohn, trying to resolve this philosophical conundrum about the nature of psychiatric illness, argues for a modified version of realism combined with elements of pragmatism and appeals for a multifactorial understanding. Clinical approaches to identifying psychiatric disorders, that is, validity. The approach is to identify symptoms which cause either distress or dysfunction, their number and duration, in order to define each disorder. The purposes of classification are to distinguish between normal and abnormal emotional states, both in non-psychotic as well as psychotic states, and to distinguish one psychiatric disorder from another. Achieving these is termed validity, and along with reliability, which is also called replicability, it is considered a basic tenet of diagnosis. Distinguishing between normal and abnormal states in non-psychotic disorders, validity, and the clinical significance criterion. As we know, when a psychiatric disorder is diagnosed where none exists, this is referred to as a false positive. If pathological and non-pathological conditions cannot be distinguished adequately, the former might be overdiagnosed, artificially inflating the prevalence rate. Interestingly, studies have failed to clearly demarcate those with disorders from those with none when relying on symptoms. Wakefield points out that zones of rarity, that is, a line of demarcation between those with and without psychiatric disorder based on symptoms, may not be sufficient, and that zones of rarity should also apply to other domains as well, such as etiology, psychosocial functioning, course, response to treatment, and prognosis, so that an absence delineation in one domain such as symptoms, a clearer delineation may be present in others, resulting overall in the identification of a valid psychiatric disorder. This is termed as explanatory discontinuity. But most of the syndromes listed as disorders in DSM-5 and ICD-10 do not meet these requirements of validity. In attempting to deal with the distinction between appropriate and pathological distress, DSM-3 introduced the idea of clinical significance. That is, the disturbance causes clinically significant distress or impairment in social, occupational, or other areas of functioning. But the clinical significance requirement is an appeal to clinical judgment. And Francis argues that this idea of basing definitions on clinical significance is likely to contain the seeds of tautology, validity, and distress-impairment criterion. While DSM requires distress or function impairment, ICD requires both. Arguably, the latter would lead to a higher threshold of making diagnosis and will have a greater likelihood of reducing the risk of false positives. Cooper argues that DSM-5 has further weakened the distress dysfunction criterion by altering the wordings. As the introduction now reads, mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. To complicate matter further, a recent study in major depression identified some symptoms, such as low mood and concentration, as having a significantly greater impact on functioning than others, pointing to the necessity for greater attention to individual symptoms rather than to overall numbers. On the other hand, the presence of auditory hallucinations in non-clinical populations is not associated with either distress or impairment, and so their presence should not lead to psychiatric diagnosis. Major depression as a case study. Lumping all the depressive disorders into a single concept was one of the most controversial decisions in DSM-3 and a possible cause of the seemingly high and increasing prevalence of these illnesses globally. Parker and Peterson suggested a two-pronged approach to major depression in DSM classification. They recommended that the disease model be applied to severe melancholy or psychotic depressive states, and that a dimensional approach be used to describe other depressive states in which differing contributions of personality and psychosocial stresses are incorporated without any natural boundary between them. Ultimately, it is likely that conditions such as major depression are a heterogeneous conglomeration of conditions which includes self-limiting reactions to environmental stresses at one end, and severe depressive illnesses with classic melancholic or psychotic features at the other end, with various etiologies and varied responses to different treatments ranging from self-help to ECT. The most common description of depressive illness was the experience of lethargy and inability to do things, whether because of tiredness or an inability to summon up effort. Also identified was a feeling of being inhibited and an inability to envisage the future, a sense of detachment from the environment, and the experience of physical changes similar to a viral illness. Clark and Kissane found that those who are sad are able to experience pleasure when distracted from demoralizing thoughts, and that they felt inhibited in action by not knowing what to do, in contrast to the person with depressive illness who has lost motivation and drive and is unable to act even when an appropriate direction of action is known. De Figueiredo identified anhedonia as a feature of depressive illness as distinct from sadness or demoralization, distinguishing between normal and abnormal states in psychotic disorders, that is validity. Interestingly, the presence of psychotic symptoms in healthy or non-clinical population has been studied with respect to hallucination in particular. These are often described as psychotic-like experiences. And studies have suggested that the quality of symptoms in non-clinical groups differs from the symptoms described by those who are psychotic. Studies have also suggested a sizable minority has first-rank symptoms, that is auditory hallucinations. But they were not distressed by the symptoms, as their content for the most part was positive and the subjects reported being able to control them. This helps to distinguish between healthy and clinical population, that is, impact on individual and benign quality of the content, distinguishing between one psychiatric disorder and another. Psychosis versus mood disorders. The classification of psychosis began with Emil Kraepelin, who without any biological data delineated schizophrenia from bipolar disorder, on the basis of clinical symptoms, family history, and course in 1893. But follow-up studies showed that a poor prognosis in schizophrenia was not inevitable. And many patients with bipolar disorder had psychotic symptoms that persisted in between depressive and manic episodes, while a large portion of patients with schizophrenia also had disturbance of mood. And current medication patterns are not particularly helpful either, since patients with mood disorders and psychotic symptoms are now variously prescribed antipsychotic and antidepressant agents. And while both conditions are heritable, they often do not breed true, and genome-wide studies have found polymorphisms that carry risk for both diseases. Even Schneider's first-rank symptoms of schizophrenia are also found in mania, demonstrating that in terms of symptoms, there are no zones of rarity between the two conditions. And course of illness itself can be misleading, as research support both continuity in some parameters and discontinuity in others for both conditions. Depressive illnesses versus generalized anxiety. It is recognized that up to 85% of those with depressive illness experience anxiety, and up to 90% of those with anxiety describes depressive symptoms. And though mixed anxiety and depressive disorder was included in ICD-10, there still remains confusion regarding whether a single condition, two separate conditions, or two conditions that co-occur at higher rate than expected by chance. DSM-4 placed it in a section devoted to possible disorders requiring further research. DSM-5 has not included it. But ICD-11 plans on continuing with its inclusion despite poor reliability and limited research on its validity. And thus controversy continues, with some researchers arguing that the mixed condition diagnosis as defined in ICD-10 should remain, while others suggest diagnostic instability and therefore caution in diagnosis. Improving validity using symptom-based approaches. In the absence of psychobiological information to guide classification, the profession remains wedded to the descriptive approach. There are two symptom-based theoretical models to psychiatric definitions and diagnosis. First one is the monothetic model, which defines certain symptoms as essential. The symptoms are narrow and very specific. Thus, those patients with specific cluster of symptoms would be regarded as likely to belong to the same diagnostic group. But the risk of not diagnosing those with atypical presentation is high, that is, false negatives. The second one is the polythetic model, which identifies a broad range of symptoms, none of which takes precedence over the others. This is the approach used in current classifications. A person has to have a minimum number of symptoms, but none is essential. Even the actual symptom threshold at which the diagnosis is made is arbitrary. Thus, there would be risk of overdiagnosis, that is, false positives. Ways to address this dilemma is to reduce the diversity of features in those with the same diagnosis. That is, to require that certain symptoms be essential to making the diagnosis, specific symptom criteria should be weighted, and finally, reducing the overall number of symptoms in the criteria. For example, PTSD gives the impression of being monothetic because it has attached weights to 4 symptom clusters. However, these are expressed polythetically. Example, any one of 5 intrusion symptoms. And for adjustment disorder, it has been suggested that if specific symptom criteria are developed, they should be weighted. For example, affect modulation. Reliability, operational definitions, and diagnostic criteria. Reliability refers to the following. Diagnostic stability over time, which is called test-retest reliability. Replication of diagnosis by other professionals, which is called inter-rater reliability. And concordance between diagnoses using different systems of classification, called internal consistency. As can be expected, reliability and concordance are important in professional communication, that is, to accurately convey information and be accurately understood. But reliability does not imply validity, since any arbitrarily drawn conglomerate of symptoms can be replicated, even when they are not a part of recognized psychiatric syndrome. And thus, to improve reliability, operational definitions are developed by DSM-3 and which have been continually updated. Concordance between ICD-10 and DSM-4. For non-psychotic disorders, it lies between 33 and 87%. The diagnosis with less than 50% agreement includes harmful substance use or abuse, PTSD, and agoraphobia without panic disorder. And the highest concordance at over 80% was for dysthymia and depressive episodes. For psychotic disorders, concordance was found best for bipolar disorder and unsatisfactory for seasonal affective disorder. Co-morbidity, consanguinity, and co-occurrence. Co-morbidity creates further issues with validity. There is much confusion about this term and it is frequently used inaccurately. The term was first used by Feinstein, who defined it as the coexistence of 2 or more diseases, pathological conditions, or clinical entities in the same patients. Others defined it as the co-occurrence of 2 diagnoses at the same time for a single patient, independently of etiology and/or pathway considerations. Or as the association of 2 distinct diseases in the same individual at a rate higher than expected by chance. and some even recommended the use of term to only refer to physical illness that is accompanied by psychiatric disorder. Tyler has attempted to restore harmony to this conceptual cacophony by describing three types of relationships. The first one is co-morbidity. It is when two or more discrete, unrelated entities are present in the same person. For example, obsessional personality disorder and schizophrenia. This might give false impression of prevalence, inflating the rates and promoting polypharmacy for each individual component that is identified, but has better outcome rates due to the same. The second is consanguinity. It is the overlap between symptoms from two or more conditions that occur together with such frequency that they should be regarded as single entity. This is more commonly seen in psychiatry, for example, schizophrenia symptoms and anxiety symptoms. The third one is co-occurrence, which can be either of the above relationships, and the term is used in cases of uncertainty as to the nature of relationship due to insufficient research evidence as in mixed anxiety and depressive disorder. And this is of more than theoretical interest, since the category will not only dictate our attention to the biology of these conditions in a particular direction but also has an impact on prognosis. Conclusion. The consequences of inadequate validation studies is that there has been a proliferation of new disorders over time based on behaviors and or symptoms that may not in fact be real psychiatric disorders but variants of normal distribution of features found in human condition.